All right, hi everyone. It's Dr. Steph, and today in office hours, we will be talking about all things pregnancy. So, how do you plan for it? How do you pay for it? And how to balance family planning with having a successful career. So, joining me today is Dr. Shirin Dason, who did her residency in obstetrics and gynecology and is now a fellow in infertility. She is part of the team that created the website familyplanningfordocs.com, which I'll link in the description below because this is a valuable resource for medical trainees and physicians on navigating pregnancy, infertility, and taking parental leave. Dr. Dason has a lot of experience with patients who struggled with infertility and has lived experience with that herself. Now she's the mom of 2 kids and a huge advocate for normalizing the conversation about family planning, particularly for those of us who delay childbearing due to our careers. So I just want to start by talking about the planning stage before getting to the pregnancy and postpartum stage. Can you share a bit of your story and about how you made that decision to start family planning and whether age played a role in that decision?
Yeah, for sure. I would be happy to. So I met my husband pretty young. I was about 19 when we met. So by the time I got into medical school and then I was in residency, the two of us had been together for a while, and it made sense in our life at that time to get married as we were kind of deciding where I would actually be for residency. So for me, finding a partner was something that was already established, and getting married was something that was natural in my relationship timeline. I would say that the decision around kids was something for me that happened fairly quickly. I'm somebody who makes decisions very quickly. I decided that I wanted to have children when I was in medical school or residency, and I think my husband took a little bit of convincing to come around to that idea, especially based on age. So I think when I was an undergrad, I thought to myself, I'm not going to have kids until I'm 30 or later. And I remember my parents being a bit shocked when I told them that, because in our culture, it's certainly encouraged to have children sooner. But once I actually got into medicine and then started moving into residency, I think I also saw a lot of role models around me, moms, resident moms, et cetera. And that kind of prompted me to think that maybe it was possible to actually make this work for us. I was also fortunate because my husband is a lawyer, so he was already kind of had his full-time job, and in some sense, his life had already started. So his career trajectory was faster than mine was. And so I think from our perspective, we had friends around us who were having children. It just kind of seemed very natural for us to get married and to start thinking about having kids. I think within my residency program as well, I was fortunate to be in obstetrics and gynecology. So we're certainly exposed to all this stuff all of the time. And I think that that kind of ramped things up for me, especially in first and second year of residency, because I certainly saw babies everywhere and people getting pregnant and family planning. And so to me, it just seemed very natural. I think what surprised me in my own journey was just the concept that once my husband and I decided that we were actually going to start to try to conceive, I actually didn't really factor in where I was in training. I actually just thought to myself, whatever happens, we'll make it work. And that was always my mentality. And I think what surprised me was actually that it was very difficult to become pregnant. And that we really struggled with infertility. And so for those first few months, I think that was when it kind of hit me that it was maybe not going to be as easy as we thought it was going to be. And I think that's where a lot of the stress came into planning for me, because I realized that actually that journey to have a child was going to be much more difficult than I anticipated. And it was not as simple as maybe we all thought it was going to be.
Yeah, and I liked how you mentioned that because I know that on your family planning for docs website, there is a bit about, starting at certain ages, fertility can start to decline more rapidly. So for more of the, I guess, general listeners on this video, after age 35 is when the fertility really starts to decline. And in the website, you had a statistic, which was pregnancy loss rates are 17 to 28% for females 35 to 39, and then 34 to 52% for females over 40. So for yourself, it sounded like the age wasn't necessarily a factor. It was just based on you and your husband's readiness. What did that conversation look like? Like, it sounded like both of you were on the same page, but did you initiate a conversation with your husband around that?
Absolutely. So I initiated that conversation during our honeymoon, which maybe
Okay.
wasn't the best time to start talking about that. We both knew, that we wanted to have children, but I kind of told him I'm ready basically now. And he said, I'm not ready. And so that he took a little bit of time for us to work out when was going to be the right time to actually start trying. And I actually was on a birth control pill at the time. And so I had to stay on birth control for a while. And I got grumpier, but eventually we convinced him that, or I convinced him that it was the right time. So I think it took a little convincing. But I think we both had very clear visions of what our life was going to look like eventually. It's just the timelines maybe in our minds were a bit different because from his perspective, I just started residency, we had just gotten married, so it made sense to wait a little bit before starting. But in my mind, I actually thought, I'm going to be in this residency program for 5 years. I'm only going to get 1 week vacations. It's not like we're going to fit in a bunch of travel or do anything that exciting. And I was ready to move on to the next phase of my life. And so that we compromised on that timeline a little bit, but I think we both felt like we had an opportunity to speak our minds and make that decision together eventually.
And did you both kind of talk about your decision or want of kids while you were still dating? Or it was something that you only started talking about when you guys got married?
Yeah, absolutely. We did talk about it when we were dating. I mean, I had young kids in my life in the sense that I had cousins with kids. And so we were actually always around kids. And I think it was very clear to both of us that we both wanted kids because of our interactions in our life. And I think we were always well established on that value. And I think we used to always talk about, when we have kids, we're going to do X, Y, Z. And we did always talk about the number of kids that we wanted, which is another important factor when we're thinking about family planning that sometimes I think we forget to talk about as a culture. We always think, making that decision to have kids starts with the first kid. And we can start thinking and having, talking about that kid anytime. But the problem is if your family plan includes 2 to 3 children, you'll have to get started sooner than if you wanted to only have one child. So when we talked about it, we decided that we wanted 2 to 3 children. So that to me meant also that I had to start getting started a little bit sooner because I had to fit 2 or 3 kids within my reproductive timeline. And I'm not sure at the time I was totally aware of my reproductive timeline because I was young. I was 25 when we got married. So, it always seemed natural to me that it was going to happen at some point. But when we talked about 2 to 3 kids, it did matter what my timeline of my career was, because if I was thinking about one kid, that may happen during residency, but then when was the second kid going to happen? And when was the third kid going to happen? And what would that all look like? And how would, my career trajectory look? And so I think that factor of realizing how many kids we want to really plan out the whole timeline was important to us.
And that's such a great point that you make, because often people will just ask, well, do you want kids or not? But not realizing there might be differences in how many kids you want. And you don't want these kind of questions to start coming up once you're already married. Maybe the other person doesn't even want kids at all or just wants one, but you want 3. So it's very hard to kind of compromise if the other person wants 0 and you want 1. You can't just meet halfway, right?
Absolutely.
The other thing that you also mentioned about was it sounds like during your residency, that's when you decided to conceive. A lot of things that patients ask me is, what are some things that you did in order to prepare for pregnancy? So once you made that decision, you're going to try. What did you start to do in order to prepare for that?
Yeah. So, I mean, what I did personally and what I recommend to patients tends to kind of merge together at some point. So, of course, I knew that I had to be on a folic acid and vitamin D, prenatal vitamin, kind of 3 months before I started trying. And so, of course, I was mindful to do that. I was on birth control at the time. So, I decided that I was going to stop about 2 to 3 months before I truly wanted to conceive. And that was because I wanted to see my cycles return because I'd been on it for a while. And that is also what I recommend to people. Although I was prepared that if I got pregnant in that first month, that was going to be totally fine with me. So I did kind of have a window of when I expected it and when I expected my cycles to return. But I also knew that I could get pregnant right away. So I was prepared for either. And then in terms of planning, so I'm definitely a planner. I know that about myself. I have agendas, I make checklists, I do all those sorts of things. So I tracked my cycle for a while. And I used to keep it in, I had the Flow app or one of these period trackers, and I used to put it in there. And so I recognized my cycle was 32 days. And I knew that I was going to ovulate kind of 2 weeks before that. And we would plan to have intercourse around that time. I was less stringent about it at the beginning for sure, but as we started to get to month 7 and 8, I think the other thing that we never talk about commonly is that intercourse gets tiring, and planning all of those things gets tiring, and planning it with your busy schedule. And so eventually we really would only have intercourse around the time of ovulation because we just didn't want to do any more than that. And that's perfectly fine, of course. And so that was kind of how I planned all of it. And also at some point, I actually stopped tracking because I found it gave me more anxiety. So even though I enjoyed it at the beginning, it started to get more stressful. And those kind of 2 week waits and doing pregnancy tests definitely took a toll on my mental health during that time. And so I actually let go of the control a little bit. And that helped, I think, in terms of my mental health and giving me a little bit more agency because I let somebody else take control. I went to the fertility doctor, I spoke to them, and I actually let them kind of guide what was happening and tell me what to do without interfering too much, which for me as a person was very helpful.
Yeah, and I really like what you said about how intercourse is tiring, because as a family doctor, usually I tell patients, or at least what we learned, is to have intercourse 2 to 3 times a week. But for, of course, busy professionals, this can be very tough to schedule in. And so when you tracked your ovulation, like that kind of limits how frequently you need to have intercourse. The other thing you also mentioned was about seeing a fertility doctor. So it looks like after several, maybe 7, 8 months of trying, that's when you sort of realized you were faced with infertility. That must have been pretty tough. What was kind of going through your mind when you came to that realization?
Yeah, it was very tough. I will tell you, it was probably one of the toughest times in my life up until, that point. And I think I was always somebody who was very open about what was going on. I spoke about it with my colleagues around me. They knew that I was trying, they knew that I was struggling. And so it was actually one of my colleagues that said, why don't you just go see Mount Sinai Fertility and find out what's going on? And at first, I was somebody who was like, oh, well, I don't want too much intervention. Then after month 7, 8, 9, I kind of got to the point where I was like, I can't do this anymore. And it was very interesting because I actually decided around that time I wanted to be a fertility doctor too. And I started doing research in fertility. And so I'd actually met, Dr. Crystal Chan from Mount Sinai. And it was just like my career and my life kind of intersected at that point. And so I kind of got in touch with Mount Sinai through my research means, but I also keep my health a little bit separate from my work. So I went to my family doctor. I explained what was happening. I got tested for, my thyroid hormone, and she did, I can't remember what other blood work she did at the time, but I remember I found out I was hypothyroid at the time. So I actually got started on Synthroid, and I remember thinking to myself, oh, this must have been it, but then it wasn't it. And I did ask her for some of the initial investigations, but she told me, that she felt more comfortable referring me to a fertility clinic to do the investigations rather than ordering them and interpreting them herself, which totally made sense to me. And so once my referral was in, then I set up my appointment. And it was actually very challenging because PGY2 is our busiest year in obstetrics, where we're on the floor all the time. We're on night float 1 in 3 weeks. And so it was actually very hard to go for this appointment that was in the middle of the day downtown. And at the time I was at Sunnybrook Hospital, and I had no idea how I was going to get there. And when I actually tried to book the appointment at the time, I wasn't able to go because of work commitments. And so that actually was more stressful because I kind of had like this issue where I couldn't book the appointment. And then I was also trying to figure out when that doctor was working at a time that I could like potentially go and see them. And so I found that part really stressful too, like actually even just making time for the consultation in my busy schedule.
Yeah, and it's actually really interesting because you come from both the perspective of a patient as well as a fertility doctor. So, for example, from both perspectives, what do you usually talk to a patient about when they do show up in your office with infertility?
Yeah, so I mean, we go through a pretty detailed questionnaire that is specific to our specialty, of course. We have a history that we go through, and we ask a lot of the important questions around gynecological history, urological history. The things that are important to us is how regular your cycles are, how you've been trying to conceive so far, if you have any specific issues that you know of, your family history. And then we start a set of investigations that will typically happen that you can do on your own schedule after the initial consultation, which look at the surface level, at your egg count, your ovarian reserve, whether your tubes are open, if you're a female. And then for a male, we do a semen analysis. And I always warn people that this is a surface level assessment. It actually does not define to me whether you are struggling with infertility or you are not. It only helps me identify whether there's actually a cause that I could specifically treat. And that's important because I think when people come to a fertility doctor and then they get all of the results and everything is normal, they actually are disappointed because now it means that there's no cause and there's nothing that can be found. And some people take that to mean they're not infertile. And I think that's not true. So the definition of infertility is that you've been trying for 12 months and you've not been successful. And that's it. It doesn't matter if we find anything or we don't. That's actually the only thing that goes into that determination. So I usually try to counsel people that right at the beginning so their expectations are set. And then they go off and do their investigations and then they come back and we have a conversation around what was found. And sometimes we find something we can fix and sometimes we can't. And at the end of the day, we have a set of treatments, and the goal of the treatments is very simple. One is increase the target for the sperm, so increase egg number. And two is increase access to the egg for the sperm. And so that's how all our treatments are designed. So I think I give people all that information up front. Sometimes people are worried about not getting personalized treatment. There's this concept of, oh, well, it's, IUI and IVF for everybody. And that's the reality. And the reality is because if you think about the definition just very simply about not being able to conceive for 12 months, now our goal is just to increase egg number and increase access of the sperm to the egg.
Mm-hmm. And you did mention several options like the IVF, IUI. Do you also talk to patients about like adoption, surrogacy, all of those options as well?
Absolutely. So I was talking about it in context, of course, of a heterosexual couple, because that's what I am in my own life. But certainly I am comfortable discussing donor egg, donor sperm, surrogacy or gestational carrier options, which are important options for people who do not have their own gametes. So either they don't have eggs, or they have a partner who doesn't have eggs, or they don't have sperm, or a partner doesn't have sperm, or they're unable to carry a pregnancy for whatever reason. And this obviously also applies to people who are in same-sex partnerships. So we are comfortable discussing those options. I will say that adoption is something that we discuss briefly as well and can bring up and connect people with resources. But if adoption is the goal, a fertility clinic doesn't typically have a lot of access to resources for that option. And so we talk about the other options and we can connect people to resources to more in-depth talk about the option of adoption.
And a lot of my patients actually are curious about the wait times for a fertility clinic, because usually as a family doctor, I can do some of the basic tests. Like I often order those like hormonal tests or the thyroid you mentioned. Sometimes I order iron as well. But then after that, let's say if it shows up as normal, but they are still experiencing infertility, what is the wait time like for me to send to someone like you?
Yeah, I think it's very clinic dependent right now, and everyone goes through a flux of wait times. So sometimes you'll have clinics where the wait time is 2 weeks, and sometimes you'll have a clinic where the wait time is 6 months. And I think it just depends on a few factors, how the clinic is moving through their referrals, but also how new the doctor is. So newer doctors are actually going to have shorter wait lists than doctors who are more established, because everybody will want to be referred to a specific doctor, and then that doctor's wait list will just balloon. And that's not necessarily a reflection of the doctor's skill or not, but it's just a reflection of the way referrals are in general in the community. And so I think Every clinic has different wait times. And so I think at the end of the day, you just send the referral and you just have to wait and see what the wait time will be. Right now at Mount Sinai, some referrals are getting through in 2 weeks. And then other people have been waiting for months. And it just depended on, the doctor they were referred to, when they referred, what was going on at that time in the clinic. So referral volumes are very difficult to manage. So it can depend. It can be 2 weeks to 6 months, and it depends on who the doctor is at the end of the day. In terms of initial investigations, I think it's perfectly appropriate to do some of those investigations, and it's very reasonable. I think it also helps some patients, to know that either my AMH was okay or my semen was okay, or identify that problem quickly. And I think it's also okay to feel that you don't have to do those investigations if you don't want to, because the fertility doctor will order them, and we use our own labs and our own imaging facilities to ask for things that are specific. And some clinics just like having, their own set of investigations that they refer back to. And I think either pathway is perfectly appropriate. So whichever one you feel more comfortable with is fine.
And you also talked about IVF, in vitro fertilization. And was that something you went through yourself? And can you talk a little bit about how much that would cost for maybe you or for a patient in general?
Yeah, so it is something I went through myself. In Ontario, you have access to one government-funded cycle, which covers the procedural costs, which are around $12,000 to $15,000. And that includes fertilization techniques such as intracytoplasmic sperm injection, which can sometimes be an add-on when you're doing it in a private cycle. It doesn't include genetic testing, which is a biopsy of the embryos to look at the chromosomal makeup. Genetic testing at this time is still considered an add-on, so it's not something that's absolutely necessary, and so it's not included in the funding. You also have to pay for your medication. So if you have private insurance, which you actually do have as an Ontario resident physician through PARO, 100% coverage, and you have $7,000 of coverage through the OHIP plan for doctors in Ontario, then you would have medication covered. But if you were paying out of pocket, the medication costs can range from $3,000 to $8,000, depending on how much you need. And that's primarily determined based on egg count. And then the last piece that you would have to pay for is storage, which is not covered by the funding. So that's about $500 a year for storage. So in terms of my own perspective, when I went through and did IVF as a resident physician, the only thing I paid for out of pocket was actually the storage fees, which was $500 a year, because my medications were covered by PARO and the procedure was covered by the government. Now, I did elect to add on genetic testing, and I did pay about $4,000 for that. And so that was an elective choice, but I could have not done that as well.
Yeah, and all those sound very expensive, right? And so if it's something that is happening to you, it's very important to start budgeting for it. It's important to look at what is covered by OHIP versus needing private insurance for. And you had mentioned OPIP. So that's the health insurance that doctors specifically can buy into. It also sounds like that took up a lot of time, right? So what was the time commitment like to go through all of that?
It did take a lot of time. And I actually chose to do 4 cycles of timed intercourse and letrozole before I did IVF. So that was 4 months of requiring cycle monitoring, which means that based on your menstrual cycle, you have to come in for blood work and ultrasound between the hours of 7 to 9 a.m. or 6 to 9 a.m., depending on the clinic, approximately 2 to 4 times per menstrual cycle, which was very challenging to arrange in residency. And it required a lot of transparency with my colleagues about, hey, I'm not going to be able to round this morning. Is that okay? Can you cover me? There is some flexibility on the fertility clinic side in terms of it doesn't have to be exactly day 13 or exactly day 14. So sometimes the give would happen in terms of the fertility clinic allowing me to do a certain day. And sometimes the give would be with my colleagues saying, I can't be here this day. Can you cover for me? But for the most part, I was able to arrange those appointments. Because I chose to do timed intercourse, I didn't actually have to come in for an IUI procedure, which would take place during the day at around 10 to 1 p.m. But I never had to do that. For IVF itself, I had some leeway. So I knew when my IVF cycle funding was approved, which was in November at the time. And I was given an approximate time that my retrieval would take place. So for the initial parts, which is the priming and the stimulation, the priming month, you don't have to do much except schedule a nursing appointment, which you can usually figure out. It is during daytime hours. It's during kind of that 8 to 3 time period. So I actually think I did it on a post-call day. And then but it was a bit flexible in terms of when it had to take place. And then for the IVF stimulation, I did have to come in again for that early morning blood work and monitoring appointments. And those were a little bit more frequent. I think there were about 4 appointments or so. And I did have to arrange that with my colleague to say, you know, I'm going to be away from, I would try to get the earliest appointment at 7 a.m. and then go right after. It was also close to work. So I was working at Mount Sinai Hospital at the time, and I would just walk back after my fertility appointment. The thing that was a bit more challenging was my retrieval, because you don't actually get a ton of notice about it. You know, it's going to be approximately 10 to 14 days after stimulation. So you kind of budget that, but you only get a 2-day notice of when it actually is, because that's when you take the trigger medication. And so it could be 1 day early, 1 day late, and it's hard to plan for that. So I actually chose to take vacation at that time, and I managed to work that out directly with my rotation supervisors. And I took that whole week off. So I think my retrieval ended up being on the Wednesday, but it could have been any time from the Sunday to the Thursday. So it gave me a bit of comfort knowing that I had the whole week off and it could happen anytime and I was going to make it work. It did take some coordination because I had to ask my rotation supervisors. I had to tell my chief, please don't put me on call that week. And so I did have to start to plan that a couple months in advance of, you know, this is the week I'm blocking off. And I actually knew that because I had regular cycles. So I was lucky because I could kind of feel like I know my day one is going to be around this time. And then I know that the stimulation is going to take place from this time to this time. And so I'm going to plan this week off. We do have some on the fertility doctor side, we do have some leeway in terms of the medications we can give you to help with scheduling. So we can use a birth control pill to help with scheduling, and we could do some things in terms of the appointments to help with scheduling. But I think the most challenging thing is making sure that you're available for that retrieval, because we do need to plan that at a specific time. After that, we have to plan an embryo transfer. So you can choose to move forward with a fresh embryo transfer 5 days later if it's safe to do so, or they're frozen embryo transfers in your other cycles. So in my personal situation, I did go forward with a fresh embryo transfer 5 days later. It didn't require much time off work. I did have to go on that day. It took me, 30 minutes to do, and then I went back to work. But I did have to go and do that. And unfortunately with that, I actually had a miscarriage, which is a whole long story. But I ended up having I think in my residency, I ended up having about 7 embryo transfers. So that was also challenging to schedule because you have to have an ultrasound, then you have to schedule the transfer. So I would say the whole process of infertility required a lot of scheduling. And I did have to know ahead of time what the fertility clinic was going to allow me to do, how much leniency I had, and sort of that timing from the clinic perspective. And then I think I had to be very open and transparent with my colleagues and my rotation supervisors about the time that I was going to be away. And I personally took a lot of accountability, which I had to, and I took a lot of responsibility to prioritize what I wanted to do in those situations and say to my colleagues, I really need this morning off. Will you cover for me? And I would say for the most part, people were very understanding. There were rare situations that they were not. And then I would try to figure things out to work that out. But I think overall, it was really just me advocating for myself in those situations.
Yeah, and it does sound like quite a lot of time, right? Was it like several months
Absolutely.
from when you started the IVF process to actual like conception?
Yes. So for my son, it was 5 months from the time I started IVF to actually conceiving him. And with my daughter, when I went back, I was using frozen embryos, and it was also another 5 months before I actually conceived her. And it took several embryo transfers before it happened.
Yeah, and that can also come with an indirect financial cost. Well, when you were a residency, you were salaried, so maybe it may not have affected as much. But for people who are making income on their own, and if they don't work, they don't get paid, it might require quite a lot of time off. The other thing you also mentioned was the egg freezing for your daughter. Can you kind of talk a little bit about the process and how that would work for somebody who is interested in egg freezing, if they're, either they haven't found a partner yet, or maybe their work is just too busy for them to go through with all of that?
Yeah. So the first part of your question about my daughter, that was frozen embryos. So
Okay.
these were from my IVF cycle. So I had 8 embryos frozen and I transferred each of those embryos in subsequent cycles. I still actually have one left in the freezer.
Gotcha.
So, and the funding actually importantly covers each of those transfers. So out of pocket, those transfers would be about $2,500 to $3,500. Some clinics are as low as $1,500. So you can see how the costs would add up with each embryo transfer. But if it's under the funding, every embryo is covered. So all those embryos were free for me to transfer. Now you can do that. So some people, in terms of fertility preservation, you can either choose to do egg freezing or embryo freezing. An egg is an egg that's retrieved from the ovary and frozen directly. An embryo is an egg that is combined with sperm in an IVF process or 𝗧cie process, fertilization. And then an embryo is created in the lab and the embryos are frozen. Fertility preservation cycles are not covered. So there is no funding available for elective preservation cycles. And there are different costs associated with that. They are the optimal time for egg freezing specifically. So in this scenario you gave me of somebody who hasn't found a partner yet, but wants to preserve their fertility for later. What we would usually tell people is that fertility is fairly stable between the late 20s to early 30s. So from about 28 to 32, we think that fertility is fairly stable because even though the bank that you started off with when you were young, it depletes throughout your life. So from the time you're born to the time of puberty, your overall bank has decreased. Your withdrawal from the bank and what we are actually able to retrieve and freeze actually increases from puberty up until kind of the mid-20s, and then it starts to fall again. And that's the withdrawal from the overall bank. So that is a bit of a different trajectory. And what we say is that your peak fertility is probably about after 25, before 30. So sometimes in those late 20s, when your AMH or your ovarian reserve, your withdrawal from the bank has reached its peak, then it starts to fall. So if you catch it kind of in that peak to fall, that's about age 28 to 32. And that time, if you choose to freeze your eggs, that's probably when they're going to be at the highest quality and quantity for your age. Now, people have done cost effectivity studies to say that if you choose to freeze at 28 to 32, and then you meet a partner at 35 and have your first kid and your second kid all before the age of 40 and never need fertility care or IVF, then maybe that cost that you spent on the egg freezing was a wasted cost. However, if you know you're going to delay, you're only going to start having kids later in your 30s, you maybe never find the right person, you decide to do it on your own. By the time you come back and use your eggs, you're 40 or 42, then certainly in those cases, it's actually more cost effective to have had those frozen eggs from before, because now you can use them to create embryos and transfer embryos. So we think that the time that the cost effectivity of eggs has been demonstrated is around age 35 to 37. So the decline has already started. So it's not going to be the same egg count as 32 or 28. However, that may be the time that you may actually come back and use them, because you haven't had a chance to meet a partner before your early 40s, and therefore you may actually want those eggs. And so the cost effectivity changes. Now, the best medical time and the best cost-effective time aren't always the same. So this is why I actually encourage everybody to think about their family plan and to come up with those numbers in your mind. How many children do you want? When is your cutoff of when you're going to start trying or stop trying with or without a partner? And try to ask yourself those questions. And if, for example, one example would be somebody who says, I would not have children without a partner until I'm the age of 43, and then maybe I would reconsider my decisions, but I haven't met a partner and I'm now 33 or 34, I would say, okay, well, freeze your eggs now and then revisit that conversation later. But if you're somebody who's kind of in this stable relationship, you're just not really sure when you're going to start trying, you're 32, maybe you'll start in 3 or 4 years, you only want one kid, it may not make sense to freeze your eggs. For you, it makes sense to wait until you're 35 or 36, start trying to conceive, you'll probably be successful. And if you aren't, you still have time to have a reasonable quality and quantity of eggs. So to me, making that family plan is actually the most important thing when you're making that decision on fertility preservation, not so much eggs or rushing for reproductive aging. In terms of, sorry, I think you also asked me costs, is that right?
Yes,
Yeah,
exactly.
so in terms of costs, that's also something to take into consideration. Any fertility preservation is out of pocket. Egg freezing is about $8,000 to undergo the procedure, $3,000 to $5,000 for the meds, but the medications are covered by Paro, so even if it's for egg freezing. And then your storage, which is $500 a year or so. If you choose to do embryos, that's an additional cost of about $2,500 to your procedural cost. So you're looking at a cost of about $10,000 to $12,000 for embryo cryopreservation. That's with sperm, either partner sperm or donor sperm. So some people choose to do it in long-term relationships because they want to delay for a really long time. I would say there's also kind of this like stuff out there about, hey, embryos are better than eggs, but I think you're comparing apples and oranges. And the reason why I think that is because eggs provide reproductive autonomy. And so, for example, Anna Kendrick came out and talked about how she regretted freezing embryos with her partner because now she can't go back and use them. And they were the eggs that she had at the time. And so reproductive autonomy is a really important consideration when you're talking about which one is better. The other thing is that an egg cell is different from the bunch of cells that create an embryo. So we talk about a difference in survival after freezing and thawing. However, eggs to become embryos undergo a form of attrition. So eggs have to be fertilized and there's a drop off there. So we have 80% of eggs will be mature eggs. 75% of those will fertilize. 50% of those will become blastocysts. That's what's frozen. However, an egg, if you just freeze it as an egg, you don't know yet what its potential is. You don't know yet how it'll fertilize. You don't know how it'll become a blast. And so even though a blastocyst has a 50 to 60% chance of implantation, and you can be certain of that even after it becomes thawed, you have less certainty with an egg. So you can see how the conversation becomes a little murky, and it's not as simple to say that embryos are better than eggs. And I still do hear that out there. But I think it's important that as a young woman, for you, probably it just makes sense to freeze eggs for reproductive autonomy than to start combining them with donor sperm because embryos are more stable or more certain, if that makes sense.
That makes sense. And what would be the time commitment like to undergo through this type of procedure?
It's the same as an IVF procedure.
Okay.
So you still undergo your priming, you have your nursing appointment, you undergo stimulation. It takes about 3 to 4 blood work and ultrasound monitoring appointments. You still have to plan for that retrieval. So you'll need that kind of week of leniency in your schedule. And then after the retrieval, now your process is over. There is no more procedures required of you. You would typically have a review with your physician. I do just want to touch briefly on the funding aspect. Now, you do still have access to your IVF funding if you undergo fertility preservation. So in the future, so say what you decide to come back and use your eggs at 36, you can't transfer an egg into you to become pregnant. Your egg has to be fertilized to become an embryo, and an embryo is what's transferred inside to create a pregnancy. You can choose to just try with your partner for a year before actually coming back and using the frozen eggs. But if you are struggling and you come back and use the frozen eggs, you can apply your government funding to the thaw of the frozen eggs, fertilize those eggs, and have all the embryos that are created and transferred under that funding model. However, you cannot do a second retrieval then. So it'll be a bit of a determination with your fertility doctor as to whether it makes sense to undergo another retrieval, fertilization, and embryo creation with a new set of eggs, or to apply your funding to the previously frozen eggs. Does that make sense?
Yeah, so what I'm hearing is that you have to kind of prove the infertility first in order to get the funding. So the 1 year of no fertility in order to get the funding, then you can apply that to that first retrieval. Is that what you're saying?
So you don't have to prove it. You could
Okay.
come back. You could say, you know what, I don't even want to try to get pregnant on our own. I just want, maybe you're single and you just want to come back and use donor sperm to inseminate those eggs and you don't want to try in any way. You don't have to prove infertility. So you can access your funding if you're going to use it right then and there.
Oh,
There's no requirement.
I see.
Yeah.
But if you're going to do a second retrieval, that's when maybe the funding may not apply.
Correct, because you have to pick which one you want to apply it towards, either the previously frozen eggs or your new retrieval. It won't apply for both.
And this is the OHIP covered funding that you're talking about.
Exactly.
Okay.
Exactly.
And just for the people who are listening who are not in Ontario, Paro is referring to the insurance coverage that hospital residents would get for as part of their residency program. All right. So that was the end of part 1 of this 2-part series on what you need to know medically and financially about pregnancy and infertility. And wow, isn't it expensive to be a woman? In the next part, we will talk about both the medical and financial side of being pregnant, postpartum, breastfeeding, and caring for a baby. Before we end, let's talk about some key takeaways from part 1. Number 1, planning for pregnancy requires both a financial plan in terms of savings and a time plan because time is income. You and your partner might be on the same page about having kids, but you might not be on the same page about when. So for couples who want to have multiple kids, it is important to have conversations about timing to make sure that you are getting pregnant during the fertile age. Number 2, intercourse is tiring, so planning around ovulation can help make it less tiring. Number 3, having normal fertility blood work doesn't necessarily mean that you are fertile. Infertility is defined as having more than 12 months of being unable to conceive if you're older than 30, or more than 6 months if you're older than 35. Number 4, fertility treatments cost in the thousands. So if you're budgeting for these treatments, make sure you look at the Ontario Fertility Program and your private insurance coverage first to help subsidize these costs before drawing down your savings. And number 5, if you are single or looking to delay pregnancy until late 30s or 40s, egg freezing and embryo freezing are 2 options. Egg freezing is preserving only your egg, and embryo freezing is preserving the sperm and egg together. So this will have an ongoing cost, which may not necessarily be covered by these government programs. So thank you for joining me in part 1, and we'll see you in part 2 where we talk about being pregnant and caring for a baby.